this webinar titled Youth Substance Use and Addiction, Timely Updates on a Critical Issue. This forum is brought to you by a collaboration between the American Academy of Child and Adolescents Psychiatry and the American Academy of Addiction Psychiatry. My name is Dr. Jose Vito. I'm a clinical assistant professor at NYU School of Medicine and also at the Office of Mental Health, State of New York. I have no financial disclosure. In terms of virtual forum logistics, all participants will be in a listen-only mode during this forum. We will have a question and answer at the end, so save your questions at that section. Please use the chat function for technical help. Note that the slides will be posted along with the webinar recording to www.aacap.org/virtual_forum by Friday, May 5th. We are fortunate to have such esteemed and dynamic speakers. They are Dr. Kevin M. Gray. He is a professor of psychiatry and assistant vice president for advancing research partnerships at Medical University of South Carolina. He will talk about cannabis and adolescent. Next, we have Dr. David Atkinson. He is an associate professor of psychiatry, UT Southwestern, and he is a medical director of Teen Recovery Program at Children's Health. He will talk about addiction and suicide in the adolescent population. Next, we will have Kevin M. Simon. He is an attending psychiatrist at Boston Children's Hospital and an instructor in psychiatry at Harvard Medical School. He is the medical director of Wayside Youth and Family Network. He will talk about adolescent substance use and the justice system involvement. Lastly, we have Dr. Amy Ewell. She is the vice chair of the addiction psychiatry at Boston Medical Center and an assistant professor at Boston University School of Medicine. She will monitor the question and answer, so please save your questions at that section. So let's begin. Our first speaker is Dr. Kevin M. Gray.
Thank you so much, Jose, and thank you to all who organized this. It's a great honor to be a part of this panel. Both organizations, AACAP and AAAP, mean a great deal to me professionally, and I love this collaboration, and I'm grateful for the audience for today's talks. So we'll get right to it. This is going to be about understanding and addressing adolescent cannabis use. Next slide, please. My disclosures, most of the research that I do is supported by the National Institutes of Health, though I am part of a multi-site study conducted by ALIS Pharma, and I've provided consultation to Jazz Pharmaceuticals. Next slide, please. So adolescents, I am excited because I imagine the audience is a mix of folks who are comfortable working in the substance use space, but less comfortable with adolescents, and then the opposite, those who are comfortable working with adolescents, but less comfortable with the substance use space. Vice versa, two different directions in this. And the greater part of my professional life has really been looking at the overlay of the two. And so we'll kind of talk about what's old and what's new. So we've long known, and for centuries and beyond, we've known that adolescence is a challenging developmental period. It's well characterized. Everything is in flux, essentially, from biological to psychological to social dynamics, but it's critically important to navigate adolescence to then achieve adulthood and independence. What's new is a couple of things. We're learning a lot more about the neuroscience of adolescence via the ABCD study from NIH and other studies, but we're also learning more about unique contexts that today's adolescents are a part of. And I imagine this audience is well familiarized with the current adolescent mental health crisis. And so they're being surrounded by novel surroundings, and we ought to be attentive to that as we think about the old and the new with adolescence. And so this is a misappropriation of a quote from a former radio DJ in England describing his favorite band, The Fall, with always a distinctive sound, but always a rotating lineup of over 30 years of releasing records and playing shows. They were always different. So the lineup, the style was always different, but they were always the same. So I want to think about this with adolescents. Again, sort of a stretch here, but just this idea is that there are some things that adolescents are being adolescents, other things are new contexts, so we ought to be attentive to both. Next slide, please. When it comes to substance use, this is one generalization, and certainly there are differences person to person with adolescent development. But I think we all have observed, either from our own history or our children or our patients, is that adolescence is not a linear progression from childhood to adulthood. And one of the things from a neuroscience perspective is we know that striatal development during adolescence outpaces prefrontal cortex development. So you have this phase in which you have more bottom-up than top-down control in terms of decision-making. So even an adolescent who is not impulsive per se is going to make decisions that adults would consider risky. They're going to value immediate reward over consideration of long-term consequences. This predicts, particularly in a context where they're interested in affiliating with peers more so than with adults, is they're likely to try new things, including substances. Obviously, one of the things we're concerned about as clinicians is that during this time when there's an increased initiation of substance use, there's also a structure and transition is more vulnerable to adverse consequences of outside influence. And so in this case, substance use during adolescence has a disproportionate impact on adolescents compared to adult onset users. Next slide, please. So cannabis, much like with adolescents, we have both old and new. So cannabis has been around for a very long time, and humans have used and encountered cannabis for a very long time, for many centuries. But what's new is certainly that policy has changed, availability has changed, and the product itself, cannabis in its many forms, has changed a great deal, even in the last decade or even 5 years, in terms of the products that are available, commercialization, depending on the jurisdiction in which you live, and marketing as well. And so youth are growing up in a time when cannabis is much more visible and much more variable in terms of product availability, and they're navigating a very different world than current adults did when they were adolescents. Next slide, please. And so, quick review on cannabis. It's a complex botanical product. Oftentimes we think about THC, that is the main ingredient that gives the characteristic high or psychoactive effect. And then we also think about CBD, which has medicinal properties, but also is present in cannabis and hemp products. Cannabis contains over 100 distinct cannabinoids. So THC and CBD are just two of over 100, many of which have not been well characterized in terms of their effects and are available or present in various amounts based on the strain and constituency of cannabis. And there's over 500 distinct chemical constituents even beyond cannabinoids. And so it's a complex botanical product. And with that, there's a lot to be learned around it. And then the novel formulations that that are increasing in popularity in the marketplace include things like delta 8 THC, as well as THCO acetate. Some may recall a few years back when there was a real surge in products called K2 and Spice, which were synthetic cannabinoids. So there's a wider variety of cannabinoids available, each with distinctive effects. And then there's different routes of administration. So we most traditionally think about smoked cannabis or inhaled cannabis. So with vaping, the advent of vaping, there's a lot more cannabis inhalation in that way than there had been previously. There's also oral ingestion. Each of it has its own risks, attributes, and other considerations. So we always are concerned about inhaling a smoked botanical product and the risk to the lungs. But we also know that with vaping, particularly THC vaping, some of the chemicals used to aerosolize THC may have lung effects as well. And so there's some associations with adverse lung effects. Edibles, in some ways, bypasses those issues with lungs, but it has the downside of not being able to titrate one's dose. So an experienced cannabis user, if smoking or inhaling, is more able to titrate the dose based on effect. With ingestion, one of the risks we see, particularly with inexperienced users, is consuming edible cannabis in a dose that's much higher than one is able to tolerate well. And so we see that as a potential concern there. Next slide, please. And one of the things that's been changed quite a bit, I'll age myself here, is that the very left side of this graph was when I was in college, and the right side is near to current. And we've seen from the time when I was in college to current times, we're now 3 times at the potency of cannabis in terms of THC content as was the case in the mid-90s. Nearly at the 4 times of that. So the plant is becoming more potent. So the marketplace has demanded a higher THC product. And so this is different than a lower THC product. And we'll get into that next slide, please. This is a bit of a busy slide, but the focus here is that the potency of THC, more so than the rate of cannabis use in general, predicts treatment admission for cannabis use disorder. So the idea is that problematic cannabis use stems more from the potency than the rate itself of cannabis use. So if we're living in a marketplace where there is higher potency THC, we're going to see a higher rate of cannabis use disorder and other related problems. Next slide. And this is going to be just a highlight of where we are with the Monitoring the Future survey, which is an NIH-funded survey that gets rates of use, attitudes toward use, et cetera, in 8th graders, 10th graders, and 12th graders. The three big ones, I just want to orient you to where cannabis is these days. So the big three that have really through my professional life have been the big three have been alcohol, cannabis, and tobacco. What's changed, as you all know, in the last couple of decades is cigarette smoking has precipitously declined in adolescence, which has been a real victory from a public health standpoint. That said, it's been replaced largely with vaped nicotine products. And then, of course, the vapes are also used to deliver cannabinoid products. But alcohol is the most prevalent, cannabis next, and then nicotine next. Other substances are much less prevalent in terms of these age groups, but of course, some of them come with very significant morbidity and mortality. So we should be concerned across the board with these, but recognizing that prevalence of use is an important variable here, even in products that are considered relatively less overall harmful than other products. We have to think about this on the spectrum. And cannabis remains a very prevalently used product. Next slide, please. So should we even be worried about cannabis? So this question comes up. I speak to a lot of general audiences about this, and I want to make sure I have a very balanced framework as I think through this, because there are a number of different very valuable perspectives when it comes to cannabis. And I'll be quick to acknowledge that many adults have occasional benign, pleasant experiences with recreational cannabis use. So I think when raising concern about cannabis use in a particular population that's at risk, I also don't want to dismiss the idea that does not necessarily go across the board. So, and we also know there's evidence of therapeutic roles of some cannabinoids. And so CBD in particular has some FDA indications for use. There is therapeutic value in cannabinoids, and it's a very exciting area of scientific discovery and new therapeutics. And that said, there may be times when benefits are outweighed by risks or alternatives. And some of that really has to be decided at the person level and at the cannabis level. So the human level is really we have to think about age, genetic predisposition to adverse outcomes with things like cannabis, is also environmental factors. And at the cannabis level, what is the product, right? So we know it's a complex botanical. And so what's the strain constituency, the route of administration? The next slide, please. And, thinking about why adolescents use cannabis, well, pretty obviously people use intoxicating substances in part to seek out that intoxicated feeling. The high from cannabis is part of why adolescents use. Also, even among those who don't enjoy it particularly, they value peer acceptance and they want to facilitate social encounters, and so they'll use for that reason. And then the group of adolescents that we're most concerned about clinically are those who use to cope, and that may have started because of peer facilitation or social factors. It started with the desire for the altered feeling. But using to cope is the one that concerns us the most because it predicts a more complicated course of cannabis involvement. Next slide, please. So other things we think about with risk with adolescents, first is any intoxicating substance has us concerned about effects on decision-making. I already mentioned that adolescents are predisposed to risky decision-making. In an intoxicated state, there's more likelihood of risky events occurring with adverse outcomes. And in particular, driving performance is impaired by cannabis use. Then with repeated use, cannabis use disorder is something that, again, is sort of bandied about as being, does it exist or does it not exist? It very clearly does exist. And it's more prevalent than previously thought. About a fifth of lifetime users develop cannabis use disorder, and a quarter of those are symptomatically severe. And of those, about a half are not functioning in any role. So, and that's a population that I see often in clinical trials and in clinic. And treatment outcomes are limited. That's part of why we're doing a lot of research with treatment development. Another thing that's of concern is use during pregnancy, potential effects on neonate and child. And then use during childhood and adolescence in particular. And that's really an area, especially the work that I'm doing, that's of importance to both to AACAP and to AAAP. Adolescent onset users of cannabis have about twice the rate of developing cannabis use disorder compared to adult onset users. And there's adverse effects on really core developmental features of adolescence, cognition and emotion. So it can impair school performance, et cetera. Next slide, please. Other reasons for concern, really, it's a dose-dependent thing. So the earlier you start and the more frequently you use, the higher the association with adverse outcomes spanning academic, occupational, cognitive, psychiatric, and substance use outcomes. I know Dr. Atkinson is going to speak to some of these as well, But cannabis use in adolescence is associated with a worsened course of psychotic mood, anxiety disorders, and increased suicidality in adolescence. Next slide. So what should we do? So first, just recognize that adolescents are navigating a complex developmental stage in a dynamic world, right? So their surroundings are changing. The context of cannabis use is changing. And we also are living in a world where their adolescents have a higher prevalence of mental health problems. As clinical providers, we have an important role to play in providing up-to-date, objective information. And I want to dispel the notion that we can make the decisions for the adolescents. Our role is to be trusted providers to help to inform their decisions, and the adolescents have agency to make decisions, but you want them to be well-informed decisions. And we should really tailor our messaging to the patient's individual context. That's one of the wonderful things about being a trusted clinician is you get to know your patient and you can tailor the message based on the patient, where they are developmentally, from prevention to assessment to intervention, but also say if there's a family history of psychosis, that will be something of particular concern in terms of a prevention or intervention messaging. Next slide. What works for treating adolescent cannabis use disorder? Well, some mainstays that many of you are familiar with: motivational interviewing, cognitive behavioral therapy, and then also a number of family interventions. While they are effective, abstinence outcomes are relatively modest. One way to bolster abstinence outcomes is adding contingency management, which is a behavioral treatment. And as yet, there are no FDA-approved pharmacotherapies for cannabis use disorder in adolescents or in adults. Our team has done some work with N-acetylcysteine as a candidate treatment with evidence of efficacy in adolescents, but not in adults. So there were discrepant findings between adolescents and adults, and we're doing a replication trial in adolescents currently. Next slide, please. So in summary, I want to reassure you that adolescence, while complicated, is navigable, and cannabis, while complicated, is understandable. And as mental health providers, we're uniquely positioned to help mitigate adverse outcomes of adolescent cannabis use and co-occurring mental health problems. We really are at the nexus of this. And one of the things that I think is really challenging is adolescents understandably perceive cannabis as something they can use to cope with negative mental health experiences. However, the epidemiologic evidence makes very clear is that cannabis use worsens the course of those psychiatric illnesses. And so we have to help to understand how to manage cannabis use as well as mental health conditions in tandem rather than as separate considerations. And so we have to think about this as a core element of our mental health practice, right? So it's not substance use here, mental health there. These are combined. And there are evidence-based strategies that may be effectively tailored to individual patient presentations. Next slide, please. Grateful for this opportunity. I want to leave time for our remaining speakers. I am here on behalf of, very proud to be from MUSC, and our group is called the Youth Collaborative, and we are engaged in research, education, and clinical provision of care for adolescents. Thank you so much.
Thank you, Dr. Gray. I'm excited to circle back with questions at the end of the presentations, and just want to remind the audience to please put questions in the chat. So with that, I'm excited to transition to Dr. David Atkinson, who will be talking about teen substance use and suicide. Thank you, Dave.
Thank you, guys. And this is going to be a scientific exploration of whether there is a relationship between teen substance use and suicide. And the clinical implications of that would be obvious if there was. So go ahead and get started and go to the next slide. I have no financial relationships with ineligible companies, substance use and suicide. First of all, we have long time known that there is a link between substance use and suicide in youth. But the question is it cause or effect? Or could it be both? Alcohol and drug, this is one study I really like. It's that alcohol and drug use in Northern Ireland. A longitudinal study from the late 80s to the present day found significant increases in suicide rates despite a calming of the domestic situation known as the Troubles in Northern Ireland. But what was interesting is that you saw social stressors decrease, but as alcohol and drug use increased, suicide rates increased alongside it. Now, are those differences coincidental? As the use of a drug increases, it could be that the drug use is causing increased suicidal ideation, but also there could be other drivers of suicide that could be increasing at the same time. For instance, social changes leading to increased adversity or decreased coping supports could happen at the same time as drug availability becomes greater to youth. Next slide. Now, the other thing when we're talking about substance and suicide is we have to cover this distinction between, are we talking about acute use, acute intoxication and suicide, or are we talking about the long-term effects? Mainly, I'm talking about the long-term effects of drug use. That means over months and years of adolescent's life. But there are some acute episodes. One that is classified here, I just threw out there, is that this psilocybin use in a teen that led to suicide during acute intoxication. So yes, that's the type of thing that can happen. But mainly when we're talking about this link, we are looking at the general, the longer term effects over use for weeks and months on suicidal ideation and suicidal risk. Chronic drug use, could also increase suicidal risk indirectly by increasing conflicts with parents, the legal system, educational systems, or even conflicts within their social networks, or shifts within their social networks due to their substance use. Chronic drug use could have neurochemical effects on neurotransmitter firing and brain connectivity, and it could lead individuals to become more prone to depression, mood lability, or impulsive responding. Or it could also be that those who face adversities and rejections in life could turn to greater drug use as coping, or due to the decreased opportunity costs of potentially, competing pro-social activities going away. If you feel like you failed, you can't get into college, then you might be more likely to be suicidal, or you might be more likely to use substance use, just because the game has changed. Next slide. So when we're looking at these pathways, it's important never to rule out that bidirectional causality is possible. And it's also important never to rule out that one underlying problem could lead to both increased suicide risk and increased drug use. And this animation will show us also, though, that we have found that drug use can feed back in this loop and actually increase impulsivity. So sometimes these directional causal relationships are very complicated. And it's often when you see a correlation, it's some of, chicken or egg, it's oftentimes a little bit of both. And it takes some complicated math and large sample sizes to tease them apart. Next slide. Acute intoxication, when we look at specific substances, I'm starting with alcohol. Acute intoxication, young adults, is correlated with suicide. And 15% of alcohol-related deaths among Danish youths were suicides. And also, though, there are chronic effects and even very delayed effects of alcohol use. High frequency intoxication at ages 15 to 16 and high inherent alcohol tolerance were both associated with the increased hazard ratio of suicide at age 33. So how much somebody drinks between 15 and 16 could be correlated with their suicide risk almost 2 decades later. Now, is that due to their opportunities in life changing, them starting to go down a bad path, or could it be neurochemical connectivity changes in the brain? And as mentioned before, alcohol use may be correlated with suicide risk due to just impulsivity underlying both conditions of binge alcohol use and suicide attempts. And data from Nairobi, Kenya has also shown that this is not just a Western phenomenon. These studies aren't just showing this link with alcohol and suicide risk in the West, US and Europe. It's also in Africa and Asia and much of the developing world. Next slide. One multinational, when we're looking at smoking, we have found that there are some increased risk of suicide in those who smoke. A multinational study found an adjusted odds ratio of 1.21 for suicide attempt with those who smoke cigarettes. Now, the statistics here got complicated because they found it wasn't a direct link, but one of the things that mediated that risk was school truancy. To smoke cigarettes, kids often ditch class. And ditching class in and of itself was one of the mediators for that risk factor. There was still some direct effect of cigarette smoking on suicide risk, but oftentimes it's the behaviors that go along with the drug taking that may be the more proximal increaser or driver of suicide risk. I think that this statement from a review article by Udiner et al. Said that smoking appears to contribute to psychopathologic disorders, including depression, the use of other psychoactive substances, psychosocial suffering, often associated with increased risk of suicide in young people. So this review article found that there are multiple different pathways towards the increased suicide risk. Now, I think that just because there's a correlation, it doesn't mean we necessarily need to buy into it. So secondhand smoke is the question, because I saw one study that linked that, secondhand smoke was also associated with an increased risk of suicide in youth. And I just don't find a causal mechanism probable here. I mean, sorry to just jump to the conclusion, but I think that could be, it's just that the cigarette smoking is a marker of some, different type of social setting for those who both smoke and are around those who smoke. Next slide. Cannabis use and suicide is controversial. We have seen that recent study by Vito in 2022 showed that in Canada, cannabis users had a higher odds ratio of suicide during the pandemic, and those who increased cannabis use during the pandemic had a greater risk of suicide. In looking at adults, when you look back on their life, about when they started, early onset cannabis use is associated with an adjusted odds ratio of 4.38 for suicide attempt versus a lower 2.56 adjusted odds ratio for late onset cannabis use. And suicidal ideation showed a similar trend. And again, is this due to a neurochemical change in adolescence or due to a temperamental difference in the kids who use young versus those who use late? Borges, I don't know if that's how you pronounce it, but 2016 found that there was higher risk for cannabis use and suicide attempt and ideation in adults, and there was greater risk with heavy use, but he was not able to demonstrate a link and really didn't have enough data in the review to figure out whether it was acute cannabis use caused increased suicidal ideation, but certainly higher cannabis use was associated with more suicidal risk. Next slide. Gobi 2019, cannabis use in adolescents was associated with an odds ratio of 1.5 for ideation and 3.46 for attempts. Almost all the research shows this, that there's a greater odds ratio for attempts than for ideation. Attempts are more rare, ideation more common. Attempts, of course, are more severe. And that is one of the things that I think does lend some credence to the idea that this may be causal. This study by AACAP includes this, quote where it was interesting that they found that cannabis was associated with suicidal ideation risk, along with other things like feeling worthless, low self-esteem, being bullied, nowhere to turn for support. But then there were also some things that were interestingly not associated in this study, and that's feeling hopeless, social media use, using alcohol, tobacco, and being cyberbullied were not associated with ideation in this study. If you do that same study again, you might find statistically there's different things that shake out. But this kind of shows that sometimes cannabis use jumps out as a risk when alcohol and tobacco do not. So it's important, that they are adjusting for the confounders of other drug use, and it seems that cannabis use itself seems to have a uniquely strong risk. Boris, in another review article, showed that cannabis use, particularly onset before age 15, was associated with greater ideation and attempt in adolescence. So again, showing this earlier onset being riskier. And Jacobs showed that greater risk of suicide attempt, planning and ideation, and suicidal attempt injury was higher for those who use cannabis, but also THC vapes. And young users, co-users were more at risk, and females were more at risk in this study. Next slide. Just to continue on with this, is that this has been a lot of studies in the past 3 years are showing this cannabis and suicide correlation. Cannabis use and suicidal ideation are positively and reciprocally related over time. So as you get more of one, you may get more of the other. There's a higher SI among those who are female or identify as another gender. And Han et al. Studies showed that past year cannabis use disorder, daily use, non-daily cannabis use were associated with a higher prevalence of SI, plan, and attempt in both sexes. So it's a pretty broad-based risk. And adolescent cannabis users don't just have higher suicidal ideation, higher attempts, as this Maria Mancia study shows. It's also, more rumination and tolerance of uncertainty, hopelessness, symptoms of depression and anxiety, and also some anomalous perception of reality. So we'll go to the next slide and investigate that, about what are the reasons for this overlap. What is the causality? I think I saw a question on that jump up. And, part of this association could be just correlated liabilities. The genes that predispose to early substance use may also predispose to suicidal ideation. Linsky did a study in 2004 that showed that was a large factor driving the overlap. And the transmissible liability index, Tartar and Vanyakov's work, showed that there's an inheritable risk for both substance use and suicidal ideation. But Agarwal did a nice study where you had monozygotic twins that were discordant for frequent cannabis use. One twin used a lot of weed, the other did not use a lot of weed. And the twin who used a lot of weed was 1.98 times as likely to report MDD and suicidal ideation. They were 2.47 times as likely compared to the identical twin. And earlier onset of use also increased the risk further. So here you have a naturalistic longitudinal twin study that shows that discordant monozygotic twins, the cannabis using twin does have a greater risk. And a very sophisticated study of Ori and all 2019 showed multivariate Mendelian randomization that 1.25 odds ratio of cannabis use with suicide attempts after multiple confounding variables were controlled, and only cannabis use showed a direct pathway from the behavior to the increased odds ratio of suicide attempts. Next slide. There are biological reasons. There could be that impulsivity factor, but also with cannabis in particular, there's a possible serotonin decrease that we've seen in rat models when 55 is a CB1 agonist. THC is also depressogenic when given to adolescent rats, but there was not that effect shown in adult exposure. It caused anhedonia in the adolescent rats, other depression symptoms. There's also the question is, could THC withdrawal be a factor increasing suicidal ideation risk? Because, agitation, restlessness, and sleep difficulties are all symptoms of withdrawal that could increase suicide risk. Next slide. And because, scientifically, I think we have well established that cannabis use in adolescence is associated as a component causal mechanism of psychosis. We have to ask, is psychosis one of the reasons why you have more SI? Cantwell showed, a correlation with high substance use and suicidal ideation, those with early onset psychosis back in '99. And when we talk about acute links, we did see with the synthetic cannabinoids that, yes, those could cause acute suicide attempts when people were psychotic under the influence of those synthetics like JWH018. Cannabis use in first episode psychosis is a risk factor for attempt ideation and planning, according to Free Sun study. And Bjorkenstown showed that substance use was associated with greater risk of suicide in first episode psychosis patients. So we do know that there is part of the risk is going to be greater in those who are experiencing psychosis. And I think that's my last slide. And we'll have some questions at the end.
Sorry, I'm muted. So thank you, Dr. Atkinson, for that thoughtful and comprehensive presentation. I just want to thank you, everyone, also for all of your questions that have been coming in. Wanted to remind people, if you can, to please put your questions in the Q&A as opposed to in the chat. It'll just help us track them a little bit better. So now we're going to switch to Dr. Simone, who's going to talk about adolescent substance use and the justice system involvement.
Yeah, thank you, Amy. And I believe I have control of the screen at this time. However, yeah, there we go. So we're going to talk about adolescent substance use in the injustice system or carceral system, and Dr. Simon. So in reference to disclosures, so research funded from NIH, consultant at Medscape Education, as well as to the Department of Justice. And so, I think it's important to acknowledge here that language matters, and particularly when we're talking about substance use, when we're particularly now talking about those in the carceral system, it's not uncommon that we have this perception that individuals who engage in substance use or individuals who have found themselves involved in legal involvement are deemed less than, or it was some fault of their own, and do recognize that there are questions from audience participants inquiring about genetics related to substance use. So just wanted to highlight, even the idea of criminal justice is a misnomer in that our current criminal justice system is not particularly just. So for the duration of this presentation, you'll either overtly hear me say injustice system and or carceral system. So I think it's important to acknowledge what the normative expectations of development are, and particularly for those who are of diverse backgrounds, since they make up, unfortunately, a greater percentage of individuals that end up in the legal system. And so when we think about, when we think about infancy and toddlerhood, obviously this is acknowledgement that there should be a gain of trust, warmth, a responsive environment. For instance, my daughter's 4, turning 5, this ability to be free, in early childhood learning and gaining a sense of self, greater acceptance, wanting to beginning to explore the world. You should be able to have fun. Middle childhood, growing peer orientation, and beginning to be more influenced, obviously, by family, yet at the same time wanting to learn where can I set my where can I test my limits. And then in adolescence and adulthood, again, you're trying to, identity versus role confusion. Who am I in my family, and who am I in society? And when we think about emerging adults, which adolescence leads into, it's yet another area where there's this exploration. And when we think about this in the context of diverse populations, although these are normative expectations, the narratives that we have, unfortunately, and here are some narratives in terms of books that I have found helpful when working with this population: Rage of Innocence, Psychosis, Between the World and Me, Push Out, The Criminalization of Black Girls in School, and then How the Word is Passed by Clint Smith. When we think about normative expectations, we espouse as a society that youth should, they're our future, they should have opportunity, yet unfortunately, there is seemingly at times an irrational fear when we have youth of color doing normal things. And as my 2 prior colleagues highlighted, we recognize that substance use may be something that adolescents do engage in. And unfortunately, when youth of color engage in it and are apprehended, the outcomes for them oftentimes or at times find them in our legal system. So let's look at the epidemiology of incarceration or carceral-involved youth. So annually, there's 30 million youth involved in our carceral system. And yes, arrests for persons under 18 have reduced by greater than 50% over the past decade. So back in 2009, it was 1.9 million, and then recent data back to 2019, little less than 700,000. And carceral-involved youth are more likely than other normative youth to have co-occurring disorders. What I'm not highlighting here, in part because I think it's important for us to be reflective of this, is there's an overwhelming representation of persons who are Black, Brown, BIPOC that find themselves in our carceral system. Thinking about those youth and the conditions that we're talking about, substance use included, psychiatric disorders are exceedingly common in carceral-involved youth. 75% have meet a criteria for a mood, anxiety, or behavioral disorder criteria. Although even that number itself, there tends to be an overrepresentation of, for instance, oppositional defiant disorder, conduct disorder. When we're talking about persons of color, 98% were diagnosed to have greater than 1 psychiatric disorder. And then again, 61% conduct disorder, 17% ADHD, 10% major depressive disorder, 8% PTSD, 2.7% psychotic disorder. And again, I think it's important for us to really try to delineate when we're looking at these numbers, which I'm presenting as evidence, what the true numbers may be, knowing that there tends to be disparities in reference to diagnoses and appropriate diagnoses when we have persons, again, of color. And when we think about the dynamics that our 2 prior speakers were talking about, how does a youth who might be casually engaging in substances find themselves in juvenile justice system or injustice system, it's really, we're thinking about social determinants of health. And so all of the factors related to risk factors for substance use disorder overlap with risk factors for carceral involvement. And so we'll go one by one, right? So adverse early life experiences. You've moved multiple homes. A parent was incarcerated or an uncle was incarcerated. That's a risk factor. Poor and unequal access to transportation. Unfortunately, fortunately, I'm at Boston Children's Hospital. Unfortunately, despite being in Boston, there are patients who I see who might have to travel 1.5 hours by multiple buses and trains, in part because for whatever reason, the Wi-Fi is not strong and they can't really do telehealth. And so unequal access to transportation is something that unfortunately exists for a subset of population. Poor and unequal access to insurance. Now, when persons are incarcerated, they are provided certain levels of care, but what happens when they transition back into the community? Oftentimes there's a gap in that, well, who's the guardian, who's the parent? And so it's not unsurprising that youth who are in the carceral system, when they get back into community, there's a long period of delay between them being engaged in care. And we already know that adolescents and there's a delay of seeking treatment as well as a delay of getting treatment upwards of a decade for the general population. So it's even greater when you have someone that's have been previously incarcerated. Area level poverty, unfortunately, thinking about, again, if you have a familial history of criminal justice system, there will be likely, it's a weathering and a tethering that we see in youth history. Homelessness, poor housing quality, neighborhood disorder, disarray, disconnection, poverty and inequality, right? All of these, unemployment, all of these factors are the reasons why youth are at greater risk for substances and youth are at greater risk for carceral involvement. So discrimination, violence, food insecurity, exposure, and what all these lead to is having reduced options or poor choices and psychological stress. So if you give someone poor choices, they're going to make a poor choice. And so that leads to our adverse health outcomes. And it's really due to an unfair and unjust distribution of opportunity. And that's in part because of policies that are in place. And so this is where thinking about going upstream for us is important. Now, knowing that these are our risk factors, and if you're in the carceral system at that time, you're likely, and you're a provider there, you're likely not going to change the risk factors at the time. But we can do certain things that aren't uniformly done, and that includes screening. So some best practices. There's a Massachusetts Youth Screening Instrument, the MASI. There's also Youth Level of Service Case Management Inventory 2.0, Youth Assessment and Screening Instrument, as well as the Structured Assessment, Violence Risk and Youth. And these are screening and assessment tools that can be incorporated into a carceral system or into a juvenile justice residential system. And unfortunately, this is not standardized. One of the questions earlier was about why isn't there more outcomes-based research? And for instance, in this space, we don't have a national system of monitoring individuals that are in our justice system because it's a privatized system. So moving forward, when actually working with youth that are carcerally involved, the best outcomes and the best evidence that we have are around the psychosocial approaches, and that's motivational interviewing, CBT or cognitive behavioral therapy, and then family therapy. And this family therapy, this is where we have to get nuanced as institutions, where we have to be able to think about, again, teleservices, because oftentimes the juvenile residential facility and where the family is from are not in the same neighborhood. Now, again, so while these treatments are effective for substance use reduction, long-term abstinence outcomes are generally limited. In part, we're talking about youth who leave the system, go back into the community, and we don't have great data in terms of what happens there. And the data that we do have demonstrates that, unfortunately, not great is happening. So there's difficulty in providing treatment in the multiple systems within a carceral system. Comment on the use of telephone. I will highlight this. So there is a difficulty in providing treatment in that even within the carceral system, where a youth might be housed before they're convicted per se, will be different than where they are post court decision. And so it actually does become rather difficult to streamline what treatment looks like, in part because there's a lot of independent contracts that are created between residential facilities. And in reference to just kind of summarizing, and I will answer that question that was posed, substance use and carceral involvement share overlapping risk factors. I think it's important to recognize even what we describe as a crime is skewed with disparities, in that I have seen individuals in the justice system and also in the regular community, they've done the same things, but one happens to be of a diverse ethnic population, and they're finding themselves seeing me through the justice system or injustice system. The other is seeing me in the traditional fashion, and that happens too often. Substance use often predicts worse outcomes, and so as the prior speaker was highlighting, if you are withdrawing from certain substances, alcohol, cannabis, opioids, you're more likely to, unfortunately, have worse outcomes in that you're not getting treated, you're going to be more irritable, more anxious, right? And again, irritability, anxiousness, despondent mood may not be recognized as those symptoms depending on what the person looks like. And so we have evidence about greater physical restraint, greater pharmacological restraint in persons, again, of color. So intervention should include family as best as possible. Service provision across multiple providers and systems is clearly not ideal. And evidence-based substance use treatment can promote positive outcomes and reduce recidivism. And even the term recidivism is nuanced here in that classically recidivism is thought to be about returning back to an incarcerated system, yet in the adolescent population tend actually not to use that term. I'm using the term because it tends to be the common term that people understand. So, unfortunately, we have a lot more work to do, but there is progress, and it's why we're meeting here today to kind of highlight and talk about these things. So I'm going to yield the virtual platform back to my colleague, Dr. Yule.
Thank you, Dr. Simone. Wonderful presentation. And I think we're going to switch now. My name is Dr. Amy Yule. I'm a assistant professor of psychiatry at the Boston University School of Medicine and the vice chair of addiction psychiatry at Boston Medical Center. And I'm excited to have, and here are my disclosures. And now I'm excited to have a discussion with our esteemed speakers and answer a few questions from the audience. Kevin, I was wondering, you mentioned 4 different books that were good books if people want to become more familiar with the experience of youth in the carceral system. If you were going to organize like a book club for trainees or for staff or faculty, like which one would you start with or pick as the first book or a good book?
So that's a great question. And I actually would say The Rage of Innocence. Rage of Innocence, and that's by Kristen Henning. It is How America Criminalizes Black Youth. And what she does a really good job is describing and she's a lawyer, by the way, a whole host of just what would be normal activities, but when there's a melon involved. So you're talking about the summer pool party. People are calling officers to the pool because people are playing music. Well, that's what kids do. They play music. It's the summer. So she does a really good job demonstrating how I'm talking normal activities become criminalized, not actual criminal activity. And so that's a book that I would start with.
Thank you. Yeah, I mean, it pains my heart to hear, these examples, but I think you and I share a few kind of patients in the same area and have seen that time and time again. Kevin and Dave, you both talked about cannabis withdrawal, and I think I've definitely had patients who are motivated to stop their cannabis use and have a co-occurring anxiety disorder or a depressive disorder, but really struggle to stop their cannabis use because of severe cannabis withdrawal symptoms, and was wondering how you manage that clinically.
So great question. So cannabis withdrawal, it's interesting, and I think y'all probably see this too, is I have some patients who are very frequent cannabis users who suddenly stop and have little to no withdrawal symptoms, and others who I would not necessarily predicted but have really difficult. And for some people, it's appetite reduction and nausea with even the idea of eating. For some, it's sleep difficulty. And we do know that sleep difficulty is a more persistent withdrawal symptom than others. But sometimes it's just really mood, irritability, anxiety difficulties. And I try to do some psychoeducation leading into an attempt to reduce or quit cannabis use, and sort of talk about the idea of that, in part it's, I use the metaphor of it's sort of like if you're in the grocery store with your child who wants candy and you say no, there will be a tantrum that you have to ride through. I don't mean to minimize the severity of the withdrawal symptoms, but that is your brain experiencing not getting what it's accustomed to getting. And there is a process of where it's worse before it's better, but let's talk about how to navigate that. And so for some people, it's sort of being very thoughtful about reducing their use gradually, and particularly for people who have difficulty with settling at night, reducing the earlier in the day use and trying to reduce the dose gradually at night. For other people, it's sort of really kind of rallying around, get some grace from your friends and neighbors and family members that you will be irritable for a while, but it's for good reason. The good news is that cannabis withdrawal is not medically dangerous, but it certainly is very uncomfortable for those who experience it. And I've worked with enough patients who have had a great difficulty with it. So I do often talk about sometimes when people experience anxiety or irritability when they're cutting back on their cannabis, they say, oh, see, cannabis was treating these things. And it's very difficult because you acutely with intoxication feel lessening of those, but withdrawal is this additive thing on top of what you had before, and it's a temporary condition. So that was a little too wordy, but part of it is you really kind of tailor it to the patient presentation. But I do talk about it if people have a cessation plan. I sort of incorporate as having some grace that there may be some symptoms that are more difficult for you than for others, and kind of work on a strategy to roll up sleeves and get through them.
Thank you. One question that came up in the chat, there's lots of great questions and responses from the panelists in the chat, but wanted to call out one just for live discussion. And so Dave was wondering, you did respond to the chat, but if you could also provide a verbal explanation or response to the question that Dr. Sainu presented, which is just, he wanted to confirm, or was talking about the association data, association versus causation around cannabis and psychosis.
Yeah, well, I think, it's the association data in cannabis and psychosis is very strong because we have so many longitudinal studies that have shown that adolescent exposure is temporally related with later onset of psychosis, and it's phenotypically distinct. Cannabis related psychosis has more preserved cognition, but still has a very severe clinical course. We can also induce psychosis in many volunteers in the lab through IV THC. And we also have an animal model that may somewhat validate the potential, but modeling psychosis in an animal is hard. But also, I think that the fact that you also have longitudinal studies that have genetic controls, like twin studies, and the association with psychosis and cannabis use persists even after you control for the genetic environment and environmental effects, I think pretty much establishes it as being a causal link in my mind at this time, but not the sole cause. And, it's not going to cause it in everyone. It's a subset of individuals who are probably susceptible to this, and we just don't know who that subset is.
Thank you. And Kevin, I was wondering, one question I had is there a way that we can support continuity of care for our youth that end up in the carceral system? I've had experiences where I am able to kind of track down whoever's case manager for them in jail, or kind of where they've been incarcerated, and I've tried to do like video visits, but it's felt like it's pretty ineffective in the sense that it's totally not a confidential space. You can, and just was wondering if there are strategies that you've used and have been successful around kind of trying to keep continuity of care or staying in touch with the youth when in that setting, just to kind of have that link and provide them a support.
Yeah, you can apply for a K-12. It gives you a lot of space and time to have a lot of conversations. Because the reality is, it really is that you need to build trust within the system. And so within my project, within the K, we have created, like a specialized open access point for individuals that are in for Massachusetts Department of Youth Services. But it literally going to the facility, despite that there's Zoom, you go there, you develop those relationships, and they have to really see that, they're undoubtedly they are going to recognize, oh, there's an academic institution potentially. There will be a misconception of what you're trying to bring to them. And so you really have to get their buy-in. And you just have to be as persistent as they are as a system in being persistent. So that's been helpful. Sometimes parents, I've had parent session after hours. And so that's generally what we do. And it's been somewhat successful, but the K provides me a lot of space and time to have a lot of meetings.
Got it. And would encourage people to look for other sources of funding if you're out there in the community in terms of SAMHSA grants or county funding, that it's a really important group of youth who are unfortunately, penalized for acting like adolescents sometimes and end up in the carceral system instead of in treatment or instead of kind of in other spaces. And so really appreciate your efforts.
Just as you're mentioning other sources of funding, so in a number of our states, quote unquote opioid settlement dollars will be starting to be handed out, and there likely will be a lot of calls for proposals about diversion programs. And so this is actually a very ripe time if you are an independent provider or with a group to be trying to collaborate with maybe your city commissioner, public health commission, or county commission, and really availing yourself or your system open, because there is going to be funding for this specifically to prevent individuals from recurring in these systems.
And being incarcerated is a huge risk factor for risk of overdose, so for opiate overdose after being incarcerated. And so another kind of reason to go after those opiate settlement dollars to support this population. So with that, unfortunately, we're running out of time, but really want to thank our panelists for very informative, comprehensive talks in a very short amount of time. And wanted to also highlight that if you're interested in learning more about substance use disorders, kind of that there are kind of resources and training and wonderful annual meetings with both organizations through both the American Academy of Child and Adolescent Psychiatry, as well as the American Academy of Addiction Psychiatry. And so we hope to see you in person at those meetings. Many of us attend both. And again, really welcome, thank you for joining this call, and thank you for being interested in learning more about this important population. So, and Dr. Vito, I don't know if you have any last comments as we end.
No, I think this has been a great event, and we are so fortunate to have such great experts and about this patient population.